is why I would want to start by telling all of us why I feel very passionate about this work and why I began maternal health advocacy for close to a decade now. I believe that's where life begins. I believe everything around maternal health is everything every woman and everyone needs to care about. And I developed passion from seeing the work that midwives put in the hospital with very little recognition, very little respect, and very, very little support. And so that drove my passion to this work. And so since I began work with the PUSH campaign, there's a number of achievements and number of just goals that we've already achieved. And I will just briefly go on to that. And then I will introduce our panelists to pick up from there. So currently I am scoping 4 countries in Africa. That is Kenya, Malawi, Tanzania, and Nigeria. I have had conversations with a number of stakeholders, including midwives associations, White Ribbon Alliance, grassroots organizations, partner organizations, and everyone else who is interested in that field. So this has gone into women rights organizations as well, and just getting to understand what is going on at in-country level. And for Africa, for Kenya, I'll begin with Kenya. And I know Sandra will speak to the midwives leading exercise that has been conducted in Kenya, but the main issue currently that we really are looking at is the issue of midwives recognition and actually their sort of recognition within the decision-making spaces, and that include policy-making processes and every other process that touches on midwives and their level of engagement. Currently, we have a Health Amendment Act that completely disregards language around midwifery, and so in the amendment of the Nurses and Midwives Act, we have seen that midwives representation has been removed out of that exercise. And we are jointly with the advocates within the country looking at how to ensure that midwives' voice is actually carried into that the Health Amendment Act, but also that there is recognition that they need to be in that council. So the act has already been passed at the National Assembly. It is at the Senate currently, and you're working jointly with the Midwives Association of Kenya and the White Ribbon Alliance, among other stakeholders, in ensuring that there is recognition for midwives first to be in that space, but also going forward that the midwives' voices is respected in other sessions as well. For Malawi, we have had a couple of meetings with both the association and the White Ribbon Alliance, among other stakeholders. The main issue coming out is that a lot of midwives are being trained, but then there is not a lot of employment that is happening, so they're not being absorbed into the workspace, and that is also very similar across the entire continent. From everyone that I've spoken to, the acute shortage of midwives, and that is particularly acute in Malawi. So we have a lot of trained midwives with very little absorption. The issue of equipment and supplies, midwives are working under various circumstances that do not allow them to give their best into it. And so conversations around coming up with an essential package, a minimum essential package of what is needed for a midwife to be able to give quality services is a discussion that we've begun. They have begun with advocates there, and how to ensure that the staffing issue is also sorted out. We've also spoken to advocates in Nigeria, and what is coming out again is still the issue of not being involved in decision-making spaces. Critical laws that affect midwives don't have midwives representation in the room. There is a lot of discouragement around double qualification is encouraged. And so if you are only trained as a midwife, chances of getting employment is difficult, and that goes against what we are trying to advocate for better education and direct entry for direct entry midwifery programs. And so in Nigeria, it is close to punishable if you are just a midwife. So you need double qualification. Many midwives are leaving the country. Retention is a problem. And so there is a gap in terms of those specific areas. Another aspect of Nigeria that is different from other spaces is that the regional different regions have different issues that they are battling with. And so for example, in northern Nigeria, there's very different cases to central Nigeria, among others. And so that is also brings in a lot of complication when doing advocacy, but also the fact that you really have to go to the grassroots to get to understand what is happening in the different regions, because you cannot get a clear picture of Nigeria by just going to one region of Nigeria. And lastly, in Tanzania, they are doing a lot in terms of training. And so they have successfully done advocacy to have midwives being trained, a specific training for midwives, and they're currently pushing for a direct midwifery program at the diploma level. And there is quite a bit to learn from Tanzania in terms of that sort of conversation around ensuring that we have direct midwifery programs that really focuses in ensuring that we have better education and people are better qualified for the work that they are doing, and not looking at midwifery as a punishment. We've spoken through the entire continent. It looks like when a midwife is not performing very well in their station, or there are discipline issues, they are thrown to the maternity section as a punishment. And so Tanzania is sort of looking at reversing that, and they are successfully actually doing it from the conversations that we've had with Tanzanian Midwife Association. So that is a snapshot of what has been going on. I am still working on putting this in a report, and that hopefully will be shared for the different countries. At this juncture, I would want to introduce my panelists. I have a couple of very experienced advocates and midwives across Africa. So we have representation from Kenya, Malawi, and Tanzania in the room, and they will be briefly speaking to the context within their countries. And I will begin with Sandra Mwarania, who is an advocate on matters maternal health and has been in this space for close to 12 years now. Sandra is currently the programs and advocacy manager at White Ribbon Alliance Kenya, and we have worked very closely in coming up with some of the issues in Kenya. And so beginning this conversation, I would like Sandra to briefly talk to us about the Midwives Voices, Midwives Demand report. And while looking at it, highlight the top asks for midwives in Kenya, and what these asks sort of say about the status of maternal and newborn health in Kenya. So welcome, Sandra.
Thank you, Patricia. And the push campaign, I'm really excited when the overview was being done. I was, as an advocate, because those are the things that we've been singing about. So having a campaign that's structured around pushing for midwives' rights and midwives' voices is just music to my ears, and I'll tell you why. So in Kenya, let me start saying by White Ribbon Alliance as a movement. We're very keen on ensuring that campaigns, works, policies, investments are really reflected, the needs of women and girls are reflected in how we plan this and how we design this. And so in 2018, we carried out a campaign called the What Women Want campaign. And what we were doing with that campaign, we were asking women and girls what their top priorities were for maternal and newborn health. And this was important because at the time when we were launching the campaign, there were reports that were coming, even in Kenya. We had just gotten the Lancet report that had told us that over 80% of women were dying preventable maternal deaths because of substandard quality of care. So we're very keen on actually getting to understand what does quality of care mean to women, and we went to ask them. And when we asked them this, believe it or not, one of the top priorities, it was actually the 4th highest ranking ask shared by over 1.2 million women and girls, was that they want to see increased, competent, and better supported midwives and nurses. And so that was we were very curious about that, because I'm sure as many people in this forum have had, when we're talking about maternal health and when we're talking about mothers complaining about the kind of care that they get, more often than not, they're blaming the midwives, right? When you talk here about the experiences, I know in Kenya, a lot of the conversations around disrespect and abuse at the facility level, unfortunately, the midwives are the ones who bear the brunt of such complaints. And so when we saw that as a top ranking ask, we were very interested in dipping dive into what that means. And so 3 years later, as part of actioning what we had had from the women and girls, we sought to find out from midwives themselves. You know, we'd heard about it from the women and girls. Now, from the midwives, what do they think about this top request? To actually fully realize that request, it was important to get the supply side. And so we partnered with ICM through the PUSH campaign to launch the Midwives Voices, Midwives Demands survey listening exercise, because we were asking them, we were keen on hearing directly from the midwives about their needs and their wants, including what matters most to them, and to bring their knowledge and experience to bear pressure on the duty bearers to ensure that we actually have their issues brought to fore. Issues around midwifery investments, because remember, the women had told us they want increased midwives, they want competent midwives. So increased already speaks to density and workforce, and we've had that there's already a shortage. Competent midwives speaks to education and training, and better supported midwives speaking to work environment. And so that translated to the investments that were needed to be pumped. So could we get the voices of the midwives themselves to bear on that? So to date, we've been able to speak to over 56,000 midwives in over 101 countries. In Kenya alone, we were able to speak to over 3,500 midwives. Now, recognizing that midwifery in itself is highly unrecognized, and those are some of the nuances that came up during our listening exercise. Getting to talk to midwives, even through this campaign, was a tall order. And so every response that we got mattered to us. In terms of the top priorities that came out, very similar to the policy priorities, the policy campaign, the policy asks that have come out of the PUSH campaign design, spoke to what we had in Kenya. At top of the list spoke to issues around the work environment and facilities, recognizing that they're key to the quality of care. And let me also just emphasize this. Every midwife we talked to, and I'm sure those who are in the room will speak to this, when you ask them what they want, before they even go to the different issues, they will start by saying they want to see a happy mother and a happy baby. That is what they care about, the satisfaction of their clients, and that is the mother and the newborn. But in Kenya, they really talked about the work environment and the facilities, and that was top, right? And when we asked them, when we dug deeper, it spoke to issues around facilities, right? Supplies, where the facilities are poorly supplied in terms of equipment, literally like cotton wool, some of the commodities that are needed to actually ensure that a mother is delivered well. They talked about space in the health facility, where you find that space and privacy is non-existent. They talked about even, again, the workforce. Within the facility, you find that you have, for 20 mothers, you have 2 midwives attending at any given time, which is completely ridiculous. They also talked about the referral system. In Kenya, the referral system is not as effective. So for instance, an emergency, you'd find that because the ambulance is not available, either it hasn't been serviced or there is no fuel, or the driver is not around. It actually came in a way in actually having emergency care. So it was poor quality of care for the mother who needed the emergency treatment. And finally, around resources and investments. Then the second sort of big ask that came from the midwives spoke to their recognition, the recognition of the midwife's role. So motivation to actually carry out their role, their recognition as an independent profession outside nursing, their role also, their autonomy in decision-making. So they spoke about staffing, promotions, and pay, which has been mentioned, that they feel that they're not paid equally for the work that they've done. They talked about poor, they're not present in leadership spaces, especially like in Kenya, we have the subnational and national leadership. Their voice is not present. We have nurses, but the midwifery space voice is not there. And then finally, around professional practice, where they have a desire to actually continue to grow their profession, even in terms of specializing, talking about midwives who are specialized in adolescent SRHR, midwives who are specialized in community midwifery, and other specialities that hasn't been as enabled in the Kenyan context. And so these are the asks that have come out, and we are now collating this and working together with the midwives in Kenya, including the Midwifery Association of Kenya, and I'm glad they're also in this call, to find out how do we move these asks, this policy asks, into action, and how does it actually come back and impact the midwife, and more importantly, result in quality care for the mother and the newborn.
Thank you so much.
Thank you.
That was really, really informative. And you mentioned the issue of midwives not being okay with the fact that they are not in leadership spaces and in decision-making spaces. And I want you to talk briefly about that in the next minute or two. And while speaking about that, you can also just update us on what happened with the Health Amendments Act and how is it that midwives a representation from midwife is not included in the nursing and the midwives council. So just speaking to both the decision-making and what are some of the missed opportunities during the process of that, the development of the Amendment Act. Thank you. Bill, sorry.
Thanks, Patricia. And I hope that Eunice, who is part of the association, will also chime in, because she's been actively involved in that process. What I can say is, speaking to the recognition of the midwifery role, there was an aspect that had been brought out that as midwives, they are not, there's no clear scope of practice or scheme of service that speaks independently to midwifery. And so when Kenya was, of course, in Kenya, we have a very rich, vibrant, I'm sure for those who know, very, very rich legal framework and policy framework around health. And so about the time when the Health Laws Amendment Bill was being amended, just to bring in, of course, to revise it and to update it, there were aspects around nursing that were included in this. And we leveraged that opportunity. That was about last year. We leveraged that opportunity to then bring in aspects of midwifery. And I must say, the listening exercise had not taken place then. So even the momentum had not really been built around pushing for the midwives' voices, even getting them on the table to speak to this. And so the actors, the MNH actors that were part of that process tried to push for the midwifery. And we did get to have some language around it. However, along the way, it was removed. But again, speaking to the reality that midwifery is still not fully recognized. And so what we're doing now, it's not a lost cause. As you're aware, Patricia, the bill is currently sitting at the Senate, and there's been movement to actually, not just from midwives alone, I must say, is from different health workers, because also we have the clinical officers who are also up in arms, and also the nurses actually are up in arms because there are a few clauses that did not speak to their needs. So there's still conversation. The health that bill has not been fully accepted by actors, and so we're hoping now, because Parliament has closed, we're about to have our elections in 2 weeks. Sorry, once Parliament comes. Once we have the Senate, because the bill is currently sitting at the Senate, we are now, because now we are armed with the evidence from the midwives. We are armed also with the midwives themselves, because the midwives are aware and they're actually interested in having their voice on the table. We are now working together to put together the asks that have come up into a memorandum, so that we'll work with that as an advocacy tool when Parliament comes, to ensure that the midwives' voices comes on board. And I must just end by saying, the Nursing Council of Kenya, who is the regulatory board, in fact, let me say the Nursing and Midwifery Council of Kenya, because that's also been a conversation, who is a regulatory body charged, mandated to really ensure that midwifery is recognized, and all these structures are put in place, are also in the conversation, right? And we're hoping to work with them because they're the ones who will help push. I mean, if anything, help with the policy and frameworks around pushing for midwifery issues at the policy level and decision-making level.
Thank you. Thank you so much, Sandra, for that. Very, very insightful regarding what is going on in Kenya. And so I'll just rope in Eunice at this point. Eunice is a member of the Midwives Association of Kenya, also a lecturer of midwifery. So Eunice, as someone within the Midwives Association, I know there is a lot that Sandra has spoken to that really resonates with the association. I want you to probably briefly just tell us what are some of the achievements that Midwives Association of Kenya has brought into the midwifery profession. What are some of the lessons that you have learned? Okay, so I was saying earlier that I don't know where I cut off, but chiming in from what Sandra has spoken to, and the work that is currently going on in Kenya as regards the midwives advocacy. I don't know whether you can hear me. Eunice, can you hear me?
Yes, now I can hear you. I don't know whether you are getting me as well.
Yes, now I can hear you right now. So I was just saying, stepping from what Sandra has spoken to regarding what is going on in the profession currently, I would just request that you come in with what are some of the lessons that you have learned within the Midwives Association. So Midwives Association of Kenya, what are some of your achievements, and what can the other midwives associations within Africa learn from what Kenya has done? I have spoken to you personally, and I know there is a lot of work that is going on to ensure that there is respect and there is autonomy to the profession. So you can share briefly the journey of the Midwives Association of Kenya, and you have 5 minutes to do that. So welcome, Eunice.
Thank you so much, Patricia. And thank you for giving us opportunity to at least speak about midwifery, given it's one of the most important aspects in maternal newborn health. So at least our voice is quite vital when it comes to midwifery issues. So first of all, let me introduce myself. I'm Eunice Asali, and I'm the Vice Secretary for Midwives Association of Kenya. And at the same time, I'm a lecturer of midwifery at Kenyatta University. And we are so privileged to be part of this push campaign, and also to be involved to know what push campaign is doing for the country. Midwives Association of Kenya, I think, is one of the newest associations in Kenya. We are 6 years old. And we came in as a genesis of the midwife was not visible within the country. So our voice as midwives was not being heard because, as Patricia had already indicated, the dual training, so that at least a midwife is able to get employment, actually made midwives now to be like part of nursing. So because of that, that is how Midwives Association was born, so that the visibility of midwives can be, of course, be escalated, so that we can push for better remuneration for our midwives, so that at least we can be seen within legislative tables as midwives. So our journey has not been easy, of course, because we had to dislodge from another association for us to create Midwives Association. So the journey has not been very easy. And of course, the other challenge is, given our country, you have to be trained as a nurse before you become a midwife. That challenge of people not knowing where they belong really, whether they are midwives or nurses. So it takes individuals actually to recognize themselves, self-awareness, that I am a midwife, for you to practice as a midwife. So a Midwife Association of Kenya, of course, has been able to push for visibility, especially at policy level. Currently, we have a representation, one of our members at Nursing Council of Kenya. And we are pushing, actually, we had actually inserted the name Nursing and Midwifery, so that we have Nursing and Midwifery Association, Nursing and Midwifery Council of Kenya, so that at least the voice of midwives can be heard even at that level of accreditation. However, we had a challenge, as Patricia has indicated, and also my friend from White Ribbon Alliance has indicated that, Sandra, has indicated that when the act came out from the MCA, I think from the county assembly, it had changed. So while we were at the table of reviewing, but then it changed along the way. And I think it's because people do not understand the difference between a nurse and a midwife in our country. And I think that's where we are coming in to amplify our voice, that actually there are two professions. You can either be a nurse or a midwife. So of course, because of all these challenges, a midwife in Kenya has to be trained as a nurse. So when it comes to deployment, even though I'm a midwife, I may end up being placed in a nursing or a medical surgical department, or departments that I may not be interested in because I've been trained to do that. But then where is the passion? So because of this, the quality of midwifery is not as good as you expect, because people who are placed are supposed to be providing.
We lost you, Eunice. I'll move on to Rose Mlay as we seek to sort the internet issue. Hi, Rose, can you hear me? Okay, so I think Rose is also having connection issues. We will move to, we will move to Luceshelo. So Luceshelo is joining us from Malawi. And is a nurse midwife mentor in Malawi with a lot of experience around midwifery. And so Luceshelo, if you don't mind, just take us through what is going on in the SRHR space in Malawi, and hopefully also get on to just tell us briefly about what is it like to be a practicing midwife in Malawi. And I hope that sort of resonates with the rest of the team in this room. What is your experience? What needs to change? What do we need to do better as a country? And hopefully it will speak to other people in different countries as well. So welcome, Luceshelo.
Thank you very much. So good to see you. In Malawi, there's a number of sexual reproductive health services taking place in various regions. So there is maternal and neonatal health mentorship, where expert midwives or just other experienced midwives go about in health facilities to be mentoring or coaching the midwives that are just coming out of school, or those that are already on the ground, but then they need refreshing on the knowledge and skills in midwifery. We also have cervical cancer screening. We also have family planning services, where various methods of family planning are being offered to various to women of the childbearing age and some youths. And also we also have basic emergency obstetric care services that are being referred in primary and secondary health facilities. So things they include manual vacuum extraction, manual removal of retained products. So all these services are being carried out by midwives who are working on the ground. We also have community-based M&A services where midwives will have to go into the communities to assist antenatal women, or also the women that have just delivered and are out of the hospital. So all of these services are being carried out by midwives practicing on the ground. You also asked me to say something on the experiences of practicing midwives and what needs to change. So in Malawi, being a midwife is a bit tough because it's, we sort of work with inadequate resources, and the environment is not all that good, but then the midwives are still passionate and they still like to do their job. There's low employment of midwives, as we already said, and as we already talked about. A lot of midwives being trained, but then not all of them are being absorbed into the system. So there's a lot of midwives that are just staying at home after finishing college. They're not employed. And meanwhile, in the health facilities, very few midwives are working on the ground with a very huge workload. So it's a bit hard to be a midwife in Malawi. And also, there's shortage of material resources and essential drugs, which are used by midwives as they work in their day-to-day routines. So there is also a bad referral system. So other facilities are very far away from the tertiary health facility. That's when women are their complications when the midwives meet complications as they're caring for women in the health facilities. They need to refer those women to a tertiary facility. But then the referral system is not all that good. The road infrastructures and also the transport system is not all that good. So there is a need to improve our referral system. And also midwives cry out to be heard, to be involved in decision making, as in they need to say what they need to be to work with. Say they have a little resources, they don't have essential drugs, but then they're not that much involved in decision making, as in to say what they need in the day-to-day service provision. So they need to be involved in decision making. Yeah, I hope I've covered everything that you wanted me to say. Thank you very much. Sorry, you're on mute, Patricia.
Oh, sorry. Yeah, thank you so much, Lucia. I think that sort of speaks to what other midwives across the continent also feel, the need for respect, the need to be treated with the autonomy and the respect that the profession deserves. So finally, I'll move to Victon. Victon is from the civil society movement, specifically a women rights, and speak to us why it's important for midwives to plug into those discussions currently, and maybe to touch a little bit on what women rights organizations in Kenya. I know you are a part of the We Lead project that looks at issues around infusing midwifery into the maternal health advocacy campaign that you are currently running in the northern parts of Kenya. So yeah, feel free to come in. You have 5 minutes for that. Welcome.
Okay. Thank you so much. I hope you are able to hear me.
Loud and clear.
Okay, thank you so much. And like you said, that we are part of East Africa, and that is the entire countries. You know, East Africa is currently getting bigger and bigger, and we highly appreciate that. And there was a need for member state countries just to come up together and come up with the East African Bill on reproductive health. And I think these are bills that started way back. Up to now, I think it is late with around 5 years, because every time it has been a conversation. And so why were we talking about the bill and why is it important. First, we need to understand that the bill was coming up with 5 major areas that every member state was supposed to make sure that they achieve. One, there is a lot of issues around teenage pregnancies, and that one was gets pregnant. Then how do we make sure that they are able to return back to school? How do we make sure that no baby or newborn is lost as a result of the process? And so that was something that is being kind of addressed also with a gender lens, and also education lens, because when we are addressing the matters around teenage pregnancy, we also want to address the matters around education. And so that is one area. All other issues, and it is a bit broad. It is not only now for the women, but you realize that even the healthcare for men is being addressed in the bill. And we are talking under men, they are really covering a lot about infections, infertility, urology, and other cases. So that is also an aspect that the bill is addressing. The third thing that the bill is also addressing are the issues around the termination of pregnancy. I know this is a debate that has cut across all over, but the truth be told is that, do we know that a woman has a right to access access abortion services, even the post-abortion services? And so that is one area that is also being addressed. And the fourth area that is being addressed with the bill is on the matters of the harmful practices. We are still not free from this. And we cannot talk about sexual reproductive health matters. We cannot talk about maternal, neonatal, antenatal if we don't address these other cross-cutting issues. And so the bill is talking about early child marriage, sexual exploitation, FGM, alongside other, like there is areas that change. And lastly, the bill is addressing matters of systems, that is monitoring and monitoring on issues around sexual reproductive health. And you realize that it gives the member state countries a role of making sure that they report. There is an office of Secretary General that they need to report to when it's come to reproductive health services. This is going to enhance partnership. This will enhance its implementation. So those are 5 major areas that this bill is coming on. Now, why is it important to tag along matters of midwifery? You cannot address all those 5 areas if you don't involve the midwives. Why? Because we know very well that when we talk about midwives, we are talking about life. And that's something that I don't know whether the policymakers, they understand. We are talking about life. We are talking somebody who understands life from conception until the time, even the time when I talk about vaccine, we are talking about immunization, all those processes, we are talking about midwifery. And so we have to tag it along from the time when we are drafting this bill. What is the space for the midwives? Are they recognized? Can a midwife walk out from Kenya and go to Uganda and we say that you are going to be employed as a midwife, not a nurse? Can you go into Tanzania and you're going to be employed as a midwife, not a nurse? Is it that today a midwife from Tanzania comes to Kenya and will be asked, do you have a nursing certificate, a nursing profession? No. You can walk in, look for employment, show your certificate as a midwife and be employed. And so as someone who has been working with the women rights organizations within Kenya, and currently I'm happy to see White Ribbon here because I think we are going to benefit from their services around We Lead project. Because one thing that I want to say is that when we are talking about drumming this support, where are we having the conversation? I think that is also something that we need to look. When we are talking about public support, where are we drumming the support? The support itself must start from the local. Because one thing that is very, very important, many a times we tend to drum support in a certain higher level. But if we can drum this support by supporting more local women-led organizations, by creating what is called grassroots mobilization, then when we are able to gather good grassroots mobilization within Kenya, Uganda, Tanzania, and all the other countries, then we rally them together and come up with a very good coalition building. Then we pull together as a team. So one thing that is very, very key, can we look money to create spaces for the local women rights organizations to actually drum the support at the facility level? It is until the perception of the people also change about midwifery. Because however much we are talking about this, right now you talk about midwifery, some people will be looking at the people who have, they are not regarded as professionals, which is a total lie. I'm sure, if not 100%, but a number of us who are here because of the midwives, not because of nurses. Because the foundation of maternity is only being understood by a midwife, not a nurse. And so that is one of the conversations that we would want to do. The second thing I want to bring on board is that I work with refugees. And you know very well that Uganda has Bidibidi. We have in Kenya, we have Kakuma and Dadaab, and we have other areas. But we find that the highest number of people who are staying within the, we call them the humanitarian and fragile settings, are close to 136 million persons. And of this population, the highest majority is women, girls, and children. And it is estimated that close to 21,000 newborn babies are being born in the such settlement. And so another thing that we are saying as a women rights organization, can we take this conversation to these areas? Why? Because midwives are being killed because of lack of security. Nobody cares about them. They toil day and night to make sure they bring alive within these settlements, but you realize no security is being offered for women, for midwives. We have a lot of issues around movement, like in Dadaab. If you are a midwife, yes, you will just be lucky that you are able to be based either within the facility, but you can't move out of a facility to attend to a case or to assist a delivery. Why? Because the environment is very hostile. And so the next thing we are saying is security. Security is very important. And we are not only talking about physical security, even social security. That is very, very important. And so these are issues we have to address, the hostility of these areas. We know very well that services at the camps are pathetic. And I want to call on all women, that is the most important thing, that if you see the life that women are living within the refugee camps, then we will not sit and say that anybody can support delivery. No, not anybody. A trained professional is needed. We are losing a number of children within the camps just because of quacks, just because somebody thinks maybe, and I want to say this, the fact that you are a clinical medicine person does not guarantee you that you can do a delivery. And by the end of the day, you go to the hospital, they are given credit, yet a midwife is being looked like you can't even explain. So I don't want to get more emotional about this, but I want to say this, that as a team, we can rally all local women rights organizations and speak unto one voice. One most important thing is us facilitating our local campaigns, and then localize the campaigns, make them understanding to each category. I believe if we can do this, we'll be able to address this matter. But let's tag along on these policies. You know, the other day we are having campaign, we are rejecting some sexual reproductive health policy that were being sneaked in. And so I want to call upon each and everyone that when we have the Twitter chats, we have the tags, come on board, because what we are speaking today is because some people did not speak about it before. And so let's start speak about it today so that the people in the future can say we did our role. Thank you.
Thank you so much, Victor. And indeed, you are an ally, a male champion there on issues around midwives and sharing the experiences of the different areas that you've worked in, and reiterating the fact that women must begin to rise up and advocate for the rights of midwives, and indeed all women rights organizations as well. I'm not very sure if there is any question from the chat. I don't know whether there is any question at all that someone can come up with, but I'm not very sure whether Rose is back. So Rose, I think, unfortunately dropped off. Eunice, can you take a minute or so?
And I'm liking the passion Victor has for midwives. And we want to hear so many of those voices all over the country, people championing for midwifery and midwives. And of course, for midwives to continue being the key healthcare workers, providing care for women in labor shifts. And I think this can only happen if we continue talking about midwives. And as I've already alluded, our legislative bodies do not understand the difference. So we need to also go there and, of course, speak about midwifery, and for them to understand there is a nurse and there is a midwife and the difference of the two professionals. So, and of course, now people in the country are getting to understand the difference slowly by slowly through the campaign, especially the push campaign that White Ribbon Alliance did. At least many people came to understand the difference between a nurse and a midwife. And I think the voice has to be heard even further. We have to push it more in every corner. And I like the fact that Victor is a lawyer and, of course, championing for midwives. I think that's quite a positive thing. And we need more advocacy to push the agenda of midwives within the country. So one of the achievements we've had is because as Midwives Association of Kenya, we've pushed for curriculum that highlights direct entry midwifery, and which we have at diploma level, bachelor's level, and also at specialization level, master's, and also PhD. So we already have that within the country. And we also have, we were involved in the scheme of practice so that at least the voice and also the midwives can be placed within the scheme of service. That even if you enter into service at diploma level as a midwife, you need to have provisions for you as a midwife. So I think those are some of the small steps we are taking in order to ensure that midwife is heard. However, we still have a long way, because in our register, especially in the Nursing Council, we only have about 70 registered midwives. So I think we need to increase the numbers, because the impact of midwives will only be felt if we increase the numbers. And that is why we are having this conversation, so that we continue pushing the agenda of midwives to ensure that there are many midwives within the country, and also people can, love midwifery, so that our visibility also and our impact can be shown through the work we do. So I think I don't know whether there's something else.
So that is perfect, and just learning from the work that has been going on in Kenya. There's a lot that has gone on already, and of course, so much more that is yet to take place. So thank you so much for your insight, and I hope that other midwives associations logged in can also learn from some of the experiences of Kenya. So thank you so much for that, Eunice. I can see a hand. I'll give Winnie a minute. We are supposed to wrap up. So Winnie, strictly less than a minute, and then we wrap up the session. Winnie.
Okay, thank you very much for the opportunity. I'm not sure whether you can hear me. Okay, yes, I'll be quick. Yes, I was so intrigued by the presentation that was done by Sandra, where she was talking about what midwives really want. most of the time in our congresses in South Africa, by the way, I'm from South Africa, a vice president of the Society of Midwives of South Africa. Most of the time we call upon the women to share with us their experiences, and we get to hear what they want and so on. So I just wanted to find out at what scale did she do this, and in which platforms or mechanism did she use to do this? Because I think that is one area that we will like to do, and maybe if she can advise which organizations or platforms or whoever that we can engage with to partner when we do this. Thank you.
Sandra, thank you so much, Winnie. Sandra, over to you in a minute.
Thank you so much, Winnie. Yeah, I mean, it's important tool that we launched to just help us with this campaign. And we did explore that when we were talking to the midwives. We didn't have it when we were talking to the women and girls, but we did use it when we were talking to the midwives. We also partnered with some of the mobilizers came from the Midwifery Association, like Eunice here. We tapped into those networks. We tapped into some of the groups, the women's groups that we had mobilized from a previous campaign to then speak to directly with the health facilities. So we actually went door to door asking midwives in health facilities what they wanted from their role. But yes, we do have a dashboard and we do have tools that we're happy to share, how we went ahead with how we implemented the What Women Want campaign and the Midwives Voices, Midwives Demands campaign to just help see how we track, how we identify the mobilizers, some of the networks that we tapped into, and more importantly, the women, because for us it was important that we work with the women to be engaged in this process, even in the asking. I hope that's helpful.
Yeah, thank you. Thank you so much, Sandra. Winnie has typed in the chat. So finally, I want to wrap this up. So we are coming together to agree that indeed there is progress that has been done, but indeed we still have a long way to go. And so from the push campaign objective and goals, we are coming together to say we need increased voices of midwives in clinical and high-level decision-making spaces. We also need to have improved pay and work conditions for midwives, what Victor cited around the dangers of what this work comes with, increased status, recognition, and autonomy for midwives from Luceshelo's presentation, increased and improved education and training for midwives. Unfortunately, we couldn't have Rose, but Rose would have spoken to this. And lastly, across board, we cannot do this without investment. And so we need to invest better. We need to increase the investment so that we ensure that the rights of women are protected as they are taken care of by midwives. So thank you very much for your time as we move back to the main room. I wish you all the best. I hope to meet you all soon, and as we do advocacy together, and as we join our hands to say, and it's time for us to push for midwives, it's time for us to push for women's rights, and it's time for us to equal the playing field. Thank you very much, everyone. It was nice meeting all of you, and I hope to see you all again very soon. Thank you.